Good evening, everyone, and thank you so much to so many of you for taking the time and trouble to come along this evening to be with me, my family and friends for this very special lecture this evening. Just to say, for those of you who tweet, we have got a hashtag for tonight, management and research there, so please do tweet. I say if you're used to doing that, because I know there are a lot of people who weren't able to be here tonight who would like to follow by that means. And I want to particularly start by thanking you all for being here, because without all of you, in all sorts of different ways, I wouldn't be where I am tonight and in the role I'm now working in at HSMC. And I think those pictures just give you a little bit of a sense of some of the different roles that I've performed over the years. And I'm glad, certainly, looking at one or two of them, that I've got a better hairdresser now than I had when I was about 10 years old. Now, the topic of this lecture this evening, in many ways, very much reflects my career to date, as Jeff has just said, working first as a healthcare manager, then as a researcher, and more latterly spending time in a research foundation as director of policy. And I've always been trying, I think, to bridge these worlds of research and practice. And then, of course, last year I returned here to the university to lead the Health Services Management Centre, and that's a department that's always sought to use evidence-based insights to train, to develop, and to support those working in healthcare management. Now, as time's gone on, I've tried to come to terms with often feeling that I either don't quite belong to the healthcare management world anymore, but also that I'm not quite sure I totally belong to that of research. And I sometimes feel as though I'm quite precariously balanced on what is often talked about as the bridge between the worlds of research and practice, or tonight particularly thinking about research and management. Examples of this for me include the fact that each summer I usually go to the NHS Confederation Conference, a huge NHS management sort of get-together. Sometimes I've been on the programme for that as well. And then usually just a few days later we'll be at Health Services Research UK. And I see an almost completely different peer group, a different set of friends and colleagues. And at Health Services Research UK we'll spend time hearing about all sorts of fantastic new research, but we'll be agonising about how it is somehow that the managers and policymakers don't seem to use our research to the extent that we'd like. So, and this issue of the extent to which research is connected to practice is not, of course, unique to healthcare. And one of the particularly encouraging things I found on returning to the university after almost a decade away is that there's a much stronger focus now on research impact. And this indeed now forms part of the research excellence framework, which is the way in which the quality of our research is actually measured here in universities in the UK. And for any of you from outside the university world, think Ofsted or Care Quality Commission. So what I'm going to do this evening is examine the nature of healthcare management and also of health services research, and try and explore what it is that distinguishes each of these worlds, and try and understand what each is trying to achieve in terms of its purpose and impact. I'm then going to explore the gap that I argue exists between the two worlds, and then setting out why that matters, and in particular what we can do to try and bridge that gap. And especially working as I do now in a department such as HSMC that has its mission to be linking evidence and practice. Now, of one thing I'm absolutely sure this evening, thinking about healthcare managers and healthcare management, you do not go in to health services management to be popular. You'll have all seen and heard accusations in the press, such as on these headlines here, of faceless bureaucrats, pen pushers, fat cats, who waste valuable money that would be much better spent on having more nurses and doctors. Now, it is in fact a myth that the NHS is wildly overmanaged. In England in 2014, the Health and Social Care Information Centre calculated that there were some 51,000 managers out of an overall staff of 1.17 million in the NHS. which represents about 3.5% of the workforce. And that compares with an average in the UK economy of about 10% for management in other sectors. So the NHS seems actually to be probably somewhat undermanaged, and it's therefore not surprising that it often struggles to achieve the many demands that are made of it, and also spends quite a lot of money buying in extra capacity from consultancies and elsewhere. And as the King's Fund Commission on Health, Leadership and Management noted in 2011, the NHS in England is a £100 billion a year plus business. It sees 1 million patients every 36 hours, spending nearly £2 billion a week. Aside from the banks, the only companies with a larger turnover in the FTSE 100 are the two global oil giants, Shell and BP. If the NHS were a country, it would be around the 30th largest in the world, and it might just as sensibly ask, how can it be run effectively with only 45,000 managers? The King's Fund clearly, they came up with a slightly different number of managers a few years before the figures in 2014. And when you also add into the hospital management community all those NHS staff who have some sort of line management responsibility, such as ward sisters, consultants, chief pharmacists, superintendent physiotherapists and so on, the figure actually goes from around 3.5% up to around 30% of people who have a management component to their job. And David Buchanan and his team at Cranfield University call these the hybrid managers, and they actually outnumber the professional general managers by around 4 to 1. So it's really important to think carefully about who we're talking about when we refer to healthcare managers, and to look critically at any rather wild assertions of huge numbers of superfluous bureaucrats, because the faceless bureaucrat is much more likely to be a ward sister, consultant surgeon or catering supervisor than to be a general manager. I just want to return for a moment to the issue of the unpopularity of healthcare management, for this is important in terms of the relationship of managers to and their need of research. In my PhD study of chief executives, one of the interviews I undertook in 2006 has stayed with me as a particularly vivid and I'd argue quite shocking description of how bruising it can be as an NHS senior manager. And this manager, she commented, if you didn't protect yourself, you would just assume that you were a complete shower of shite, for that's everyone's view of you from the health secretary down, that the managers are rubbish and got us to where we are, can't calculate the money, and so on. The primary requisite to being an NHS chief exec at the moment is emotional resilience, not your intellectual capabilities or know-how. Now, David Buchanan at Cranfield refers to NHS management roles as extreme jobs with long hours and intense demands. And these extreme aspects can be potentially really demotivating for the people who occupy those roles. For example, dealing with competing priorities, having to do more with less resource, the burden of external regulation, and a climate of negativity, just to name a few. And this unrelenting pressure on NHS managers is evidenced in the high level of turnover. My PhD work showed an average tenure for a chief executive of 2.9 years. And a commission on NHS leadership undertaken by the Health Service Journal just last year showed the median time in post for an NHS chief executive to now be just 2.5 years. Now, this makes life as a Premiership football manager look actually quite stable and long-term. And I do here have to offer sincere apologies to my family and friends who support Aston Villa. Although it is a good day to be from the East Midlands today. So. Now, as my former boss at the Nuffield Trust, Nigel Edwards, has written, he said, high executive turnover in the NHS has a chilling effect on the willingness of chief executives to take bold initiatives and encourages a passive and responsive culture. So these are very difficult jobs, and the rapid churn has an impact on the overall management culture and the ability to get things done. It's important to note that international research, such as the work of Ross Baker in Canada, Steve Shortell in the United States, and our own Russell Mannion here at HSMC in Birmingham, it's clear that high-performing healthcare organisations need consistency of leadership and a healthy culture over the longer term. So here we have a blatant example already of a yawning gap between our NHS healthcare management practice and what the research evidence actually advises. And the vital importance of healthcare management is perhaps most evident when things go badly wrong. When in 2010 I was appointed to work with Robert Francis on his inquiry into the events at Stafford Hospital, I felt, on behalf of my original profession of health management, the rather piercing gaze of a senior legal team who were trying to understand how it was that a hospital's board and management could preside over such poor and neglectful care. And Sir Robert Francis made it clear in his inquiry report that the buck did in fact stop with NHS management. This is from his statement on the day that the inquiry was published. He said, "What brought about this awful state of affairs? The Trust Board was weak. It did not listen sufficiently to its patients and staff or ensure the correction of deficiencies brought to the Trust's attention. It did not tackle the tolerance of poor standards and the disengagement from senior clinical staff from managerial and leadership responsibilities." And health services researchers have likewise been challenging and critical of healthcare management at times, most typically in relation to managers' lack of attention to research evidence. One such critic, who has himself spent time directly engaged with NHS leadership as a long-serving chair of an NHS hospital trust, is Professor Alan Maynard from the University of York, who noted in 2012, "Local autonomy and a preference for what is invented locally by amateurs in isolation from the evidence base dominates managerial decision-making. This creates replication of evidence-free innovations which waste resources and, due to poor evaluation, rarely add to the evidence base." And this echoes work such as that of Sue Dobson in Oxford and Christine Edwards at Kingston University, who've underlined the fact that managers tend to like to learn from other managers or through intermediaries, hearing about people's experience of doing similar work. Thus, they prefer to read research summaries, attend conferences, or learn in workshop settings, which is probably unsurprising when you think about the very social and people-focused nature of management. Before we go on now to explore the world of the health services researcher, I just want us to pause and consider for a moment what it's actually like to be a health service manager. And to help with this, I interviewed Alex Borg, who's Deputy Director of Operations at the Birmingham Children's Hospital, and he's kindly agreed to let me use this clip in the lecture today.
If you put me next to a patient, I'd be terrible. I don't know. I'm not very good at physiology. I have no idea. I'd make a terrible doctor or nurse. But I feel that doing what I do still allows me to at least contribute towards making people's lives, society, just that little bit better. The Children's Hospital, I mean, working here specifically is, you know, if I'm honest, I think when I came to work here, I don't know that I thought I'd stay as long as I have. So I've been here for 3.5 years and don't really have any plans to go anywhere. I think that it's a lovely place to work, and that's one of the key things. I think the bit that I enjoy most is probably the diversity. So it's the fact that I turn up for work, and yes, of course, I've got an agenda in terms of my calendar. You know, I know what I'm supposed to be doing, but inevitably something will happen throughout the day that means that it's just that little bit different. My role itself allows me to sort of get involved with and talk to a range of different people, from, you know, patients and their parents and families through to the exec team, and so I get quite a lot of variation there. I'm learning every day, and I think that's quite important. Not a great deal, I don't think. I mean, obviously, you know, I've referred to some things already, just in terms of, well, okay, we know that a different generation might respond differently, and so there's probably the beginnings of a different approach as a result of some of the research that's been done. But I don't think when we're making decisions on a day-to-day, I think it's a lot more intuitive, a lot more based on, you know, it worked like okay before, so all things being equal, it will work okay again. I don't think we'd sit there and think, well, the best research, the best evidence suggests we should be doing that, and therefore that's what we're going to do.
I think you'll agree that Alex demonstrates here the rather pragmatic approach of being a healthcare manager, working on a diverse range of issues, things that will of course include ensuring safe levels of staffing, making sure there's sufficient operating theatre capacity, that outpatient clinics are running properly, managing budgets while trying to meet requirements for efficiencies, and also responding, of course, to calls from staff and patients for improvements or changes to services. Now, one of my main academic collaborators over 20 years, Professor Kieran Walsh, who's here with us tonight, he's commented on health managers and what it is they do. And I think this is a very helpful a summary of it here that's taken from a book that he and I are publishing just in July. And here Kieran says, managers and leaders in healthcare systems spend too much time doing things and too little time thinking about what they do and why they do it. Life as a manager in any organisation is frequently stressful and frenetic, with disruption and interruption to tasks and activities commonplace. So healthcare management, it's unpopular, pressured, and often isolating. It's undertaken by people who work phenomenally hard and who have a strong commitment to sustaining and improving health and care. But what's less clear is the extent to which evidence and research inform the role and activities of healthcare managers. So I want us now to turn our attention to the people who actually create that evidence and research with the hope of influencing management practice, the health services researchers. In preparing this lecture, it was striking to note that there's a lot of research about healthcare management, what it is, why it's important, and how it can be improved and so forth, but relatively little about those of us who do the research. Now, that's probably unsurprising because it would arguably be rather self-indulgent for us to be spending scarce research funding on studying ourselves and our role, but given the persisting concern about separate communities or worlds of research and practice, I do think it's important to try and understand the experience, role and priorities of those who create the evidence intended to improve and change health management practice. Now, health services research is a broad field and it draws together various academic disciplines, including public health, health economics, management science, organisational studies, medical sociology and more. And it's a relatively new branch of research. For example, Health Services UK, Research UK, which is our national network, was founded just some 15 years ago as part of trying to give us a stronger identity as a group of researchers. Now, a major European study of the health services research community took place in 2011, led by another of my long-standing academic collaborators, Professor Nick Mays of the London School of Hygiene and Tropical Medicine. I think he's also here this evening. And in that, Nick and his colleagues underlined the importance of health services research in being able to, and I quote, help understand and enhance an effective relationship between decision makers, other stakeholders, and researchers. So being absolutely clear there that health services research is about a relationship and about the research helping to inform decision-making and practice. And this same study pointed out that there's health service research that takes place at a national level. So for example, you can have studies, or there are studies that compare the performance of the health systems of the 4 different countries of the UK. You get some that's at what we call the meso, or the middle level, which, for example, might be trying to understand why some hospitals are safer than others. And a lot of it that's actually at the micro, at the patient level, which could be about, for example, trying to decide whether one treatment is more effective than another for someone who's got asthma, for example. And I know that this evening there are people, colleagues in this room, whose research takes place more at one of those levels than the other. But collectively, we're all trying to inform the delivery of improved health services and care. And I think this rather diverse and emergent nature of health research is both appealing and appropriate because it does offer us the potential of mixing methods and disciplines in ways that enable us to undertake some quite nuanced analysis of really complex issues that face us in the health service today. So just to give you an example, at the Health Services Management Centre at the moment, we've got work going on, for example, trying to find fair and transparent ways in which you can ration scarce health service funding. We've got work exploring in depth the experience of older people who have to have an emergency admission to hospital. We're involved in a project that's trying to understand why you're more likely to die if you're admitted to hospital at a weekend than on a weekday. And we're also doing work to establish the extent to which hospital boards and leadership have responded to the Francis inquiry into Stafford Hospital. So in short, what we're trying to do is to produce evidence that will help health managers make better judgments about how money is allocated, how services are organised, and ultimately care improved. Now, the UK is the second highest producer of health services research in the world after the United States. Interestingly, the Netherlands are third. We have generous funding for health services research, particularly through the National Institute of Health Research. And so I think there's a significant responsibility on our shoulders in terms of demonstrating accountability for that investment in us and the impact of that research. Now, you may also be sat there thinking, I wonder what it is they actually do as health researchers. So I want us now just to listen for a moment to another clip, this time from a HSMC colleague, Dr. Catherine Needham, and she'll talk here about her role as a health researcher and how she tries to achieve impact in her research.
So health services research, I think, is such a fascinating area to be involved with because it's got such a rich kind of applied knowledge base. You're really getting into some of the key debates that are going on around practice. But it's also very well theorised, there's lots of interesting ideas, and it's that ability to bring the ideas and the practice together that I think makes health services research really fascinating. So I think a typical day depends to some extent on what stage you're at in the project. So some of what you're doing in the early stages might be applying for grants in order to get some money to do the project. When you've got the grant, you might be looking at the literature, writing ethics review forms. And then after that, you're out on the road, and so you're undertaking interviews with people, perhaps face-to-face, maybe in people's homes or in hospital settings. You might be doing focus groups with small groups of people to talk to them about how they're feeling about particular services. You might be administering questionnaires to people, and some of that may be face-to-face, or you may be doing that by email or using other kinds of ways to get that out there. So there's a range of different sorts of practices depending on where you're at in terms of field work. And once you've got the data, then you need to be probably back at the desk analysing it on your own or in groups, and then thinking about how you want to get it out into the world and making sure you're having conversations with people who might be using the research along the way. So you're not expecting to just sort of produce the research at the end and expect people to notice it, that you're really thinking along the way about how people might be using this and how it can have an impact. So in terms of increasing impact, I think there's partly about the speed with which we communicate. So academic work does take a long time to get out into the public domain if you go through the peer-reviewed journal route. So we need to be quicker and more agile, I think, about thinking how we get things out through social media, through blogs, through short reports that can be easily digested by managers and policymakers. And that we also can be opportunistic in terms of thinking, right, there's a debate suddenly appeared in the media. My research, my current research, my research from a few months ago really speaks to this. How can I now get something out through a blog, for example, or using Twitter, so that I can make the links for people when they might not have the time or the headspace to make them for themselves?
So I think what we've heard there from Catherine is a set of really quite different activities, of course, from those that would be undertaken by a healthcare manager. And as one who's worked as both a manager and as a researcher, I think it's fair to say that researchers have much more flexibility in how they plan and organise their work. They face far fewer on-the-day demands and distractions, and are, of course, as well, much more likely to be working alone or in smaller teams. And I think an important reason for why health services researchers work as they do actually lies partly in the way that their performance is assessed and what is actually deemed as success in career terms. Because first of all, academic careers are rather solitary endeavours. Short-term contracts define the early years until a lectureship can be secured, and even after that, promotions are weighted very much in favour of individual rather than collective achievements. There's a pretty clear set of metrics for academics that include, and it can feel like this, publications in what we call peer-reviewed journals. Those are international academic journals that have very stringent standards for accepting papers, albeit that the peers who do the reviewing are other academics and very rarely the managers or clinicians who actually use the research. But counting citations of one's work in other academic papers, securing major research grants from prestigious funders, presenting your findings at international conferences of researchers from the same field, all of those are very important. And these metrics have been around in academia for many years. On my return to the university world, after, I say, nearly a decade away, I've actually been struck by a much stronger focus on the quality of teaching and student experience, which I think surely has to be a good thing, but also this emergence of research impact as a priority. And I'm going to return to research impact in a moment. And I'm hoping, if you can see that one there, that the research impact we'll talk about will be more constructive than what's depicted in this cartoon, albeit that I think most PhD theses could probably knock someone out quite easily should one be so minded. Let's move on now to explore why should we mind the gap. Healthcare managers clearly inhabit a very different world from that of most researchers, and yet the researchers need and want to make a difference to how healthcare is organised and delivered. In terms of what managers and policymakers tend to say they want from research, we usually hear the following. They want evidence of what works or might work in certain circumstances. So, for example, whether we should use financial incentives to try and get GPs to undertake more vaccinations or to screen for dementia, for example. Or, as I mentioned earlier, managers are often eager to have summaries or syntheses of what the research tells us about a particular issue. So that could be, for example, whether it's a good idea to replace face-to-face consultations in general practice with consultations by phone, email or Skype. And third, managers will often want to know if there's evidence that actually help them know how to best implement a particular innovation, drawing on studies of prior attempts to do this elsewhere. So again, an example there might be if you were wanting to move from paper-based to electronic prescribing in your hospital, you'd want to know what to look out for, what's happened in other examples and where those have been researched. But what healthcare managers do not want from large and expensive research studies and find very frustrating is conclusions that say, well, on the one hand and on the other, or, well, it all depends, and worst of all, more research is needed. Now, this highlights the fact that the choice of what to research is critical in addressing the gap between management and research, and a point made, again, very strongly by Kieran Walsh in our forthcoming book. I think he might have been slightly cross, Kieran, when you wrote this, but I think the general point holds. It's going to be in print. It is astonishing, he says, that this research community chooses what to research, undertakes its research, and then publishes in journals with almost no reference to the needs, interests, and perspectives of the management community. The leading management research journals are simply not read by anyone other than researchers. Management research is essentially applied social science, and it should be providing the evidence that managers can then use in practice. And this seems to me to contrast with a lot of patient-level research, which is typically reported in a manner that I would argue probably makes more sense to the doctors and nurses and other clinical staff who will be hopefully using it, albeit we know it can take many years for implementation to become widespread. I'm a fellow of the Royal Society of Medicine, and on an almost daily basis, I'm sent information about seminars, workshops, videos, and other updates about, that are of everyday concern to doctors and other health professionals in their clinical, and sometimes indeed in their managerial and leadership work. And they're offered as part of continuing professional development. And continuing professional development is currently not a requirement for health service managers, which contrasts for most professions. And an important factor here is that a lot of health services research links more closely with clinical practice than with management, because most hospitals, mental health trusts, community trusts, and increasingly networks of general practices host and take part in clinical research studies. They support students who are undertaking research as part of their training. And clinical meetings within hospitals, community services, and general practice will often explore some new research. And doctors, nurses and health professionals will often attend research conferences as part of their professional development. But for the management community, however, the connection with research and researchers, I would argue, is weaker. And academics such as Thomas Rundle in the States have written about the absence of a strong research culture in health management and the tendency to prefer experience-based learning that we noted earlier. Now, there have been various national initiatives to try and draw health research and NHS organisations more closely together. For example, we have collaborations for leadership in applied health research and care, CLARCs we call them, and academic health science networks. Now, while these initiatives have been important, my contention today is they've not yet been sufficient to address this fundamental gap between health management and research. I think we're often continuing to address the symptoms rather than the cause. And I think this lack of engagement between health management and research probably reflects a deeper reluctance on the part of academics to take impact seriously. Because it's actually, if we're honest, easier to focus on presenting one's work to peers, which of course has its place, but it's actually much more challenging and uncomfortable to do so to those who we wish to use our research findings, for that's going to call for different ways of working that often don't fit with our career priorities and preferences. And for managers, pragmatism and busyness just too often crowd out time for finding out the latest research evidence about health management and organisation. Little time is typically made for reading, for reflection, for attending research-based events, and as I mentioned, there's no requirement for continuing professional development. And managers rely very much, and arguably too much, on the briefings and activities of intermediaries such as the King's Fund and the Nuffield Trust, and typically have less interaction with perhaps their local or other universities in relation to research that could actually inform their management practice. So moving to the final part of my lecture, how can we bridge the gap? I think we first of all need to be really honest about the challenges that face the researchers, but also challenges that face managers. It's a game of two halves here. For researchers, I think we have to ask, why do we keep on largely doing what we've always done and then complaining that policymakers and managers don't heed our very excellent findings? And why do we also hold back from making recommendations based on our research? I think perhaps it's in our nature often to be cautious. And also, how might we better summarise our findings in a much more accessible manner? And most critically, if we want healthcare management to be evidence-based, are we brave enough to act on the evidence about how managers often don't use our research? But there's an equally uncomfortable set of challenges, I think, for health services managers. Why do we find it so hard to make the time to read and learn from the latest research? Are we afraid of being challenged or of having to challenge what we're being told from on high? And can we articulate better the issues where we need help from the evidence? What help might we need from researchers, foundations, or others to do this? Now, the Canadian academic, Professor Jonathan Lomas, influenced me significantly when he came to HSMC back in the 1990s to share his, what were at the time, groundbreaking ideas about a new form of health services research that would be designed, undertaken, and disseminated on the fundamental basis of trying to bridge policy and practice. And in a seminal paper that he published at that time about the need for this different approach, Jonathan Lomas talked about the sound of one hand clapping, a very vivid depiction of what he considered to be an often futile effort on the part of health researchers seeking to have an impact. And Lomas must have influenced me more than I realised, because I'd done the synopsis for this lecture, it had all been advertised, before I actually went back to Lomas's papers when I was writing the lecture, and realised that he had referred directly to this idea of two worlds, of two separate worlds. And in doing that, he drew on work of Kaplan from the 70s, which in turn was drawing on C.P. Snow's conceptualisation of the distinction between the humanities on the one hand and hard science on the other. Now, as a central part of his work, Lomas advocated what he called a linkage and exchange model, with 4 significant groups identified. First of all, the decision makers, people working in policy management and practice, who set issues and priorities for research funders, who then come up with questions and fund programs of research. The third group, the researchers, who then actually do the research, create evidence and ideas. Then he talked about the knowledge purveyors, and I'm going to focus on them particularly in this last part of the lecture. He was meaning people like think tanks, the media, these third-party intermediaries, people who come up then with the lessons or the stories even, or the facts, as he put it, and ultimately that those evidence, the idea being that those evidence-based ideas then go back to the decision makers and you have this sort of perfect circle. But that looks terribly logical and appealing, but for me it's a bit too linear, and particularly when I think 2 decades later, I think we need to reimagine the work of Lomas in a much more complex and shifting age of online and internet, social media, virtual learning, open access publishing, and where there's a much more fundamental concern for research impact. So my argument is we can no longer leave it to third parties to do the knowledge purveying. I think we, the researchers, have to now be those knowledge purveyors. And in doing so, ask some tough questions of ourselves about how we actually undertake our research, let alone how we disseminate it. And also, I think there has to be a whole new relationship between researchers and decision makers, researchers and managers, working with those colleagues right from the outset to determine what's the research we should be doing, involving them much more closely in the work that we do. Now, if we really want to do what the University of Birmingham, certainly for all of us working here, this is absolutely clear in the university strategy, we are intending and hoping to make important things happen. Now, if we want to do that with our research, I think it's us who's got to ensure that our research has impact. We cannot leave it to others, carrying on doing what we've always done in the way that we've always done it. And I just want, as I draw to towards my close, to draw on my experience here of the 6 years I spent working in one of those more what are traditionally known as knowledge purveyor organisations at the Nuffield Trust. I got 4 what I think are important insights from my work at Nuffield. First, we spent significant amounts of time thinking about the audience for our research, and were helped in this by having senior and experienced communications and public affairs colleagues alongside us as part of our team. Second, we work closely with people from that audience for our research, often in roundtable sessions and discussions where they would help us design a study. And that really influenced our choice of methods, in particular leading us often to use routine data, whether that's financial or activity data, alongside qualitative work. Because all my experience tells me managers and policymakers, they like to have numbers, they like quantitative data to support proposals alongside qualitative research that can point to how and why change might work. Third, as we were a charity, we had to demonstrate public benefit in all we did. And this meant we put a lot of time and effort into developing our own metrics of impact alongside those of the REF. Because yes, the Research Excellence Framework still mattered to us when I was at Nuffield, because a number of us were researchers hoping to return to academia at some point, which some of us clearly have. And the final point I took from that experience was that we made a significant investment in communications and public affairs expertise, which was critical to being able to act as a knowledge purveyor and work in what, for me, coming from academia, was a very different and more connected manner, with sophisticated plans for dissemination and follow-up of each report or article that we published. And returning to the university world, I hear so much more than I did a decade ago about impact and engagement. But I have to say I'm struck by how relatively underdeveloped those activities still are, and appear often to be quite isolated within central and sometimes they can feel quite remote university functions. So to bridge the gap between health management research, I'm going to end with some challenges for researchers and some challenges for managers. So for the researchers, what I think we need to do is we have got to face the fact that healthcare managers are busier than ever running health services and always will be. So we academics, we've got to ensure that our research speaks to the concerns and priorities of managers. And second, I think we have to acknowledge that we are the knowledge purveyors with responsibility for translating, sharing and explaining our findings to those who can use them to improve patient care. And that will likely mean us using, and for some of us, this is going to, including myself, this will be new and often scary. You need to use channels such as The Conversation, which is an academic blogging site, BuzzFeed, Twitter and others, alongside carefully crafted research summaries, podcasts, vodcasts and briefings and more. Third, we need to use this role of being research purveyors to really question how we undertake our research and take seriously approaches where policymakers and managers are involved throughout the life course of a project. And we can learn from the growing body of co-produced research where studies are developed by academics and practitioners in tandem. We can also learn from the experience of the policy research units that have been in place now for several years, funded by the Department of Health, and also from examples from the states, such as the integrated piloting and evaluation work that the Centres for Medicaid and Medicare over there undertake. And this is a point that Health Services Research UK, together with the Health Foundation, have been making strongly recently. And in this excellent BMJ paper, led by Tara Lamont and others, it sets out in a really helpful way for those of us who are researchers the range of emerging and mainly mixed methods, approaches that are now available for more sophisticated but more engaged methods of evaluation. And fourth, and the final challenge for the researchers, is that I think we have to see ourselves as the conveners, the communicators, the supporters of implementation, those who draw together managers and practitioners to learn from, to challenge and explore our research findings. And we can learn here from the research foundations and also specialist evidence brokers, such as one I've worked with in Australia, the Primary Healthcare Research and Information Service. But we can also build on our own experience here at HSMC in mounting specialist research-based policy events for local NHS leaders, like one we did here actually with colleagues in Manchester back in the autumn when the spending review was announced by the Treasury. Now, in case you think I'm letting the managers off scot-free, I'm not. They too face 4 important challenges about how they can ensure that their work could become, I'd argue, slightly more critical and evidence-based. I think, first of all, healthcare management needs to think really seriously about how it could become a properly accredited profession with compulsory continuing professional development, and hence accessing and having to access research-based learning and updates, as is the case indeed with health management in some other countries. And I think the management community actually also needs to demand more of the research that it already hosts and funds in local hospitals and primary care networks and other trusts. And this actually challenges researchers within medical schools to work more closely with those of us who study the organisation and delivery of healthcare, and vice versa, for us to work more closely with colleagues in medical and clinical education. And examples, particularly impressive examples, I would say, of how this can be done, include Muir Gray's work in Oxford, where he advocates what he calls right care and choosing wisely, using evidence about what works or doesn't in a clinical sense to inform the way in which services are funded and organised, and often leading, in fact, to less being provided because it challenges us about not delivering ineffective healthcare. Third, I think managers do have to commit time to become seriously involved in helping to commission health services research, so it starts to answer the questions they really want answered. And research funders, I'm afraid, need to find nimbler ways of doing that. And I know lots of this has been tried over the years, but because the process as it is at the moment will be too cumbersome and time-consuming for the busy manager. Fourth and finally, for the managers, and particularly looking into their representative bodies like NHS providers and the NHS Confederation, they need to forge stronger relationships with those of us in research teams and universities, alongside the think tanks and research foundations with whom they tend to already work very closely. This might entail practical initiatives such as paired learning, where individual researchers are linked with individual managers to learn from one another, but it could also be about the NHS Confederation, NHS providers having a much more significant component of research within the programmes of their annual conferences, rather than quite so much content that tends to be much more about learning from practical experience, as I mentioned earlier. But for us researchers, that would again challenge us. How would we make our work accessible in those sort of settings? So to conclude this evening, both researchers and managers need to become better at occupying this uncomfortable territory between the two worlds. Researchers need to become true knowledge purveyors, and managers have to find ways to become more systematically evidence-based in their work, something that I think could help build further their professional status, including in the eyes of their clinical colleagues. So we all have to mind the gap, but we have to ensure it's not only minding in terms of being concerned or worried about the gap, but minding in terms of attending to or urging to action. Now, looking back to Judith in 1987, that's how I looked when I turned up on the management training scheme, as a fresh-faced graduate embarking on the NHS scheme, she got no idea about the possibilities of the internet, genomic and precision medicine, social media, digital and open access publishing, big data, or the many ways in which we can now try to bridge the worlds of management and research. But the challenge for us now is to ensure that by using all of these and all the various things that lie ahead of us that we don't even know yet, that the next generation of healthcare managers will be properly evidence-informed as it makes tough decisions about how to sustain and grow our NHS. And researchers as knowledge purveyors will have to, I think, find ways to make sure we've really got impact at the heart of all we do, relishing the new ways of working that this presents. If we can get closer to achieving this, I think we'll have truly gone a long way towards bridging the gap, and we'll no longer need to say, mind the gap. Thank you very much.
Judith, thank you so much for your inaugural lecture. And let me say who I am. I'm Saul Becker. I'm the Pro Vice-Chancellor and Head of the College of Social Sciences. And the Health Services Management Centre is one of the departments in the college that I work in. It's a pleasure and a privilege to be able to say a few words by way of thanks to Judith for her lecture, and just to sort of take up a couple of those themes in just a couple of minutes before we break, and you can have time to talk about it and to meet others. Judith, in her typical way, gave a very considered lecture, and yet behind all of that is a profoundly radical theme. It is the theme about two parallel worlds, the world of research and the world of health management. But actually, those parallel worlds apply to many of the spheres that we work with in the social sciences and beyond. In social care, in other forms of government policy and local authority policy, these parallel existences that take place between those of us who research the important things that matter and those who use research or who don't use research for policy making, for practice, for decision making, for informing the allocation of resources. And behind what Judith said, I think is an important radical agenda for trying to bring those two areas together. I think the cost of us not doing this is the continuation of those two parallel worlds. The continuation of researchers who do work which is incredibly important, but often doesn't have any impact whatsoever on practice, whether it's in health, social care, or any other sphere, and those who rely heavily on evidence, and research evidence in particular, to help them make very important decisions. If we do not bring those worlds together, in a much better way than we've done in the past, I think we continue to fail our patients, we continue to fail the systems and reduce the health gains that we would wish for people who are vulnerable or with health needs. The research agenda, and the REF in particular, the Research Excellence Framework, which Judith mentioned at the start, our Ofsted, I didn't think I'd ever really say anything publicly in praise of the REF, but I do say something which is in praise of it, which is that the impact part of the REF has forced academics to think much more about how do we get our work out there? How do we translate it, transfer it, work with other partners to co-produce knowledge that's important, that's relevant, that's timely, that's accessible, and that can be used to inform the decision-making that Judith talked about. And I think that REF agenda around impact has forced us to do that. And in the university, we have an infrastructure to help us think through how do we do those kinds of things. But Judith is absolutely right that we're still not good enough at doing that. And there are many parts of what we do, many areas of our research which still don't get translated to inform policy or to inform practice. And tonight we've heard very much about how that takes place or doesn't take place in health management. The challenge for us as academics is to engage with the wisdom of Judith's inaugural lecture, to think through the various elements and proposals and suggestions and her challenges to us as academics and to some of you as health managers, and think through how we actually bridge that gap and bring together those two parallel worlds. And certainly, as a Pro-Vice-Chancellor who's got a responsibility for engagement at the university level, there are many inaugural lectures I listen to, and there are many that I don't agree with, but I have to say I agreed with every word of Judith's inaugural lecture. And I think you raise an important challenge for all of us to think through how do we initiate and implement systems, organisations, and motivate and reward academics who want to become more engaged and more impactful, and how do we create the bridges with policy and practice so that our work will be useful and relevant and co-produced with those who need it. I hope you will join me in saying to Judith, that was an excellent inaugural lecture, not just one which had a lot of wisdom behind it, but which was beautifully crafted and structured and which was accessible to all and was very enjoyable to listen to. So, can we thank Judith for her inaugural lecture?